Hi, my name is Ziv Peled, and I'm excited to be discussing an upcoming paper in PRS on estrogen-associated headaches and whether or not they are amenable to surgical intervention by the groups at the MGH and Ohio State University. Chronic headaches, such as migraines, are a huge burden to the medical system worldwide. Conventional therapies consist of medical management and conventional modalities such as acupuncture and massage. However, many thousands of patients obtain little to no relief with these modalities. As a result, over the last 22 years, the field of headache surgery has developed with nerve decompression and occasional removal of permanently injured nerves, with success rates in the published literature of anywhere from 69 to 95% in nearly 100 peer-reviewed studies to date. What the authors did in this particular study was they retrospectively reviewed their experience with headache surgery over a 13-year period and identified a cohort of 99 women, 51 of whom had estrogen-associated factors with their headaches, such as the onset of puberty or menopause, the onset of headaches with menstrual cycles, or association with pregnancy, and 48 patients who consisted of the control group that had no estrogen-associated factors with their headaches. They looked at one of the most common metrics we use, which is the migraine headache index, a composite measurement taking into account frequency, severity, and duration of headaches, and assessed patients at 3 months and 1 year postoperatively. The results of this study are important for two primary reasons. Number one, it is yet another paper that highlights how successful surgical intervention can be, with nearly 80% of patients demonstrating a minimum 50% reduction in migraine headache index at a year postoperatively. Secondly, while the authors were unable to demonstrate that estrogen-associated factors had any association with improvements in migraine headache index, what they were able to show is that patients with estrogen-associated headaches did just as well with surgical intervention as those patients that had no estrogen-associated factors, such as patients who have headaches as a result of trauma, thus potentially opening up surgical intervention for a whole new subset of patients who were not previously considered candidates. I think the authors also do a great job highlighting the limitations of their study, such as the need to accrue more patients so that we can assess outcomes in different areas that we treat, for example, the frontal versus occipital regions. But they do a great job of highlighting why headache surgery is such a wonderful area for future research and also such a rewarding area for clinical practice. Thank you for listening.